Welcome to another episode of Reboot with Dr. Arasi Maran. I'm your host, Dr. Arasi Maran. And in this episode, I'm joined by my colleague, Dr. Brian Houston. Brian, welcome to the show.
Hi, thanks, Arasi, for having me.
Yes. Brian, tell us about yourself. What has been your journey so far?
Yeah, absolutely. So I never know how far back to go with questions like this, but I grew up on a farm in the middle of nowhere in Tennessee. So I'm a farm boy to start. Went to undergrad at a tiny little liberal arts college in Mississippi, and then really fell in love with the medical profession. Actually, in high school, I used to work summers for our local family practice guy, a rural doctor that literally did all care from cradle to the grave. He delivered half of the county where I lived and saw them all the way through their life, would see 50 patients a day. It was really amazing. And so was very inspired by that. So went to medical school out of college. I went to Emory and then did residency and stayed on for fellowship in cardiology up in Baltimore at Johns Hopkins, and fell in love with caring for patients with heart failure and thinking about how to treat those folks, including heart transplant or mechanical pumps called left ventricular assist devices, or LVADs. So I spent 8 years in Baltimore training to do that. And in 2016, I joined faculty down here with the Medical University of South Carolina in Charleston, and have loved every minute of it. Been down here, this is my 8th year now.
Fantastic. I mean, just looking at your patient profile you teach or you take care of, it's the LVADs and the heart failure patients. They are truly some of the sickest people.
Yeah, it's a really diverse population, but we certainly take care of a lot of sick folks. I spend a good bit of my time in the cardiac intensive care unit, caring for folks before transplant and LVAD, through the moment of getting that therapy. And then afterwards, I also see folks in clinic, again, both before and after transplant. So I get to see people all along the spectrum of their heart failure disease and diagnosis and treatment. It really is one of my favorite things to do, to tell patients, to call them in the middle of the night and say, we've got a transplant for you. You've been waiting for years for this, and we've got your new heart. It's absolutely a miracle every time.
Absolutely. I can imagine that. I mean, the whole family's life is going to change. And I mean, it's such a blessing. It's such an honor and privilege to be able to do that, right? I think that's the best part of our jobs, to have those very personal moments.
That's right.
So,
Yeah.
Brian, the title of the show is Reboot with Dr. Arasi Maran. Recently, just being your colleague, I've noticed some changes. I've noticed some rebooting happening with yourself. Can you talk about that?
Yeah, absolutely. So, I'm married. I have 2 kids, and as you know, life as a faculty member takes a lot of time, and family life takes a lot of time. And I noticed that in my late 30s, and I'm going to go ahead and age myself. I turned 40 a couple of years ago. I wasn't spending time and energy taking care of myself. And had really let things like my diet and my physical fitness and maybe even my mental health kind of lapse. And so when I turned 40, I thought, I'm not getting younger. I'm not young anymore. I'm kind of striding in the middle age. And it's probably, if I don't do it now, I'll never do it. And I listened to actually several podcasts about ways to approach, physical fitness and kind of mental health in your middle age. And one line stuck with me. Someone said, you should live your life like you're training for the 80-year-old Olympics. And what that means is you want to be able to, be at your grandkid's wedding and dance at your grandkid's wedding and do things that, would put you in the top 10 or 20 percentile of 80-year-olds. And that was really motivational for me. So I changed my diet. I really focused on eating much more vegetables and plant forward, really common sense things, lean proteins and vegetables. Lots of fruits, and cutting out the cheap calories. And then I took up running. I found that was something that I could do. I signed up for a marathon, 2 years ago, a half marathon, and then last year a marathon. And that was motivational enough to get me out there and putting in the miles, and was able to complete both of those.
Absolutely. I love that statement. We are all, we've done we found our spouse, we found the job we love, we found passion in that. Now it's about training for our 80-year-old marathons. And, for me, it's not going to be a marathon, it'll be a hike, but that's my plan.
Yeah, it took me a while to find what fitness thing worked for me. Traditional, Pilates. I know that works for some of my partners, or going to the gym 3 times a week. I wasn't motivational enough, but running just clicked. I don't think it's the right thing for everybody, but for me, it just got me out there.
Absolutely. I mean, it's different strokes for different folks, for sure. I've tried running 6 times and I've failed miserably, and that's it. My running days are over. But I love the Peloton. I love the bike.
Yeah.
I love, I love strength training a lot, but, different things.
Right.
So now let's get to the meat of the podcast, which is heart failure, but not heart failure in the traditional terms. Like I had Sheldon Littman come and talk about diastolic heart failure or the stiffness of the heart. But with you, I want to talk when the heart as a pump fails. It fails to squeeze and, just becomes bigger and bigger and becomes this really floppy organ. So let's talk about that. What are the major risk factors or reasons why a person would get heart failure?
Yeah, it's a great question. And it's for such a common disease. I think it's something where we're still learning about the epidemiology of it, how many people truly have this disease and what the risk factors are. I think the things that are pretty incontrovertible are that it's getting more common. And we call this systolic heart failure or heart failure, where, as you point out, the problem isn't relaxation or stiffness. It really lies in the strength of contraction. So it's getting more common, both worldwide and specifically in the United States. And increasingly, we're seeing that risk factors such as obesity are rising to the fore. So if we were to categorize risk factors from kind of disease development, things like obesity, hypertension, cigarette smoking, those would probably be some of the top 3. Now, all those can contribute to the development of ischemic heart disease, or the disease that you treat, which is blockages in the coronary arteries. The downstream effects of those, if you survive your heart attacks or ischemic heart disease, is often heart failure. And all those risk factors, so obesity, diabetes, cigarette smoking, hypertension, can lead to the development of ischemic heart disease. But it can also lead to what we call non-ischemic cardiomyopathy, or a heart that is weak without any blockages in the coronary arteries. It's about half and half when you look at the epidemiology. Half of my patients have ischemic heart disease and about half have non-ischemic. And the non-ischemic arm can be made up of many different causes. Some patients can inherit genes from their family members that cause heart failure. Some patients can get a myocarditis or inflammation of the heart muscle that can cause it. And there's a huge bucket list of other causes. But underlying all of that, exacerbating the risk, things like obesity, diabetes, hypertension, cigarette smoking, all these things that we can enact meaningful change with lifestyle before the development of disease.
I mean, I can imagine how frustrating it must be for a patient when they don't know why they have the problem. I mean, when you have blockages, it was because of blockages, and at least you have a goal to treat, but the non-ischemic arm can be extremely frustrating. And how do you tell your patients, like, what can you tell them to give them hope that, there is light at the end of this tunnel?
Yeah, you've really hit on something I think fundamental. And I tell patients up front when I meet them, we're going to investigate the cause of this, because everyone wants to know why. Why did this happen to me, right? It's a very reasonable and fundamental question. And I tell them, look, there is a significant chance that I'm not going to be able to answer that question right now. But I also tell them my ability to answer that question now is much better than it was 10 years ago, 15 years ago, 20 years ago. And through the advent of advanced imaging techniques, such as cardiac MRI or cardiac PET, we're diagnosing much more inflammatory cardiomyopathy. One of the diseases I seem to see a lot of and specialize in is cardiac sarcoid. Mm-hmm. The prevalence of that disease is rising, not because the disease is more common, but because we're better at diagnosing it. Similarly, our knowledge of genetics and our ability to get rapid, affordable, reliable genetic testing on patients has markedly improved. And about 20% of the time, maybe a little more these days, for my non-ischemic patients, I'm able to find a pathogenic genetic variant to say, this is the reason why, you have cardiomyopathy. We found it. And then we can give really meaningful counseling, genetic counseling, family counseling. And increasingly, we have gene-targeted therapies for patients, either in clinical trial or coming out that are approved. So I think it gives people hope to say we're better at it than we used to be at finding a reason why you have heart failure, specifically non-ischemic cardiomyopathy. And in 5 or 10 years, we're going to be even better at it than we are now.
So, again, systolic heart failure is such a specialized little disease, right? What would the patient feel? How would they even think, hey, am I at risk for this? What should I go check for? Should I even talk to a doctor?
Absolutely. I think one sobering fact is that about half of patients who have, when we look at an echocardiogram, an ultrasound of the heart, about half of the patients that have reduced systolic or squeezing function, they're asymptomatic, or they would not endorse symptoms when you really question them. I think some of that is the patients get used to a new normal. Mm-hmm. So it becomes normal not to be able to walk up the stairs without feeling short of breath, or walk to your grocery store or out of the parking lot. And so they may not even recognize those are symptoms. But when my patients do become symptomatic, they're kind of a classic set of symptoms. And you can combine them and kind of put them in two categories. One is low output symptoms. So the body is not getting enough blood flow. And those are symptoms like fatigue. They will feel short of breath when they try and exert themselves, and just a general lack of energy or get up and go. And then there are congestive symptoms. So when the heart doesn't pump fluid forward, it backs up or congests the organs behind it, the lungs, and then the liver, the belly, and the legs. So my patients might feel short of breath when they lay flat and that fluid collects in the lungs. They might have edema or swelling in their legs. So if you can push on your legs and make a big dent, that swelling is not normal. And heart failure is one of the things that can cause that. So congestive symptoms or low output symptoms, those kind of two big categories.
I mean, it's so funny how both of these categories, you can easily pass that off as, oh, it's not a big deal. I'm just growing old. I'm just out of shape. I've gained some weight. It's not a big deal. I just have to slow down. And how many times have you seen patients where they go to the emergency room and get treated for pneumonia or bronchitis? And, that happens quite a bit, right?
Innumerable times in my career. I used to have a mentor attending when I was a fellow that had a joke that azithromycin and Medrol dose packs caused heart failure. They don't, but it was just because, especially among my younger patients, so people that are 40, 45 or younger, when they show up to an emergency department with a cough and shortness of breath and fatigue, it's just the common things that spring to mind for urgent care or emergency department physicians are, oh, you've got a viral bronchitis. We'll give you a Z-Pack and a Medrol dose pack. You'll be better in a week or two. I've seen patients that have been to their ER 5, 6, 7 times before they finally get diagnosed with heart failure.
I mean, it's the younger population, again, who's so vulnerable, right? Because the 35s to 45, they don't consider themselves old enough, but they're not young enough. And they just fall through the cracks of, oh, it's not going to happen to me kind of a situation almost, right?
That's right. And not only does the patient have that sentiment, but I think providers do as well. This 30-year-old in front of me, they can't have heart failure. And so it doesn't even spring to the front of the differential diagnosis. Now, as a heart failure doctor, that's all I see day in and day out. So it's number one. It's number one on my list. And so it seems easy and obvious to me. But I'm also not seeing 100 viral bronchitis patients for every heart failure patient that I see. The really really tough cases are the ones where you see the diagnosis being missed and then they show up in my ICU really, really sick, in what we call cardiogenic shock. So their organs aren't getting blood flow. They're having multi-system organ failure. And you think, gosh, if we had just made this diagnosis 3 months ago when they first showed up with complaints, we could have been out of this situation.
I participate in the shock call, right? In MUSC, we have a shock team. And every time we're on call, all of us get, like about 5 to 6 of us get in the middle of the night. And the stories you hear, the background stories, is always heartbreaking. How did this get missed? And especially the young patients, and that it's truly, it's I wish we could have reached them sooner. And I think that's part of the purpose of this podcast, that do not ignore your symptoms. And especially if you are short of breath laying down, there's no bronchitis which should make you feel short of breath when you're laying flat on your back.
That's right. And one of the convenient parts of this disease is that the screening tests are really non-invasive, very low risk, almost no risk. So you can look for signs of myocardial congestion with a blood test. And then you can look at the way the heart squeezes and relaxes with an echocardiogram, which is just an ultrasound.
Yes.
So there's no radiation involved. It's non-invasive. If you have these symptoms and you say, gosh, this doesn't feel right, I should be able to do these things without feeling short of breath. It's a trip to your primary care doctor or urgent care and say, look, I heard this podcast. I'm worried if I could have heart failure. What do you think about an echocardiogram or a blood test?
Absolutely.
Those things are really easy.
Now, let's say they do that and now they have a diagnosis of heart failure, that the heart as a pump is not working well. What is the next step?
Mm-hmm. So your next step should be to establish care with a cardiologist. I'm a cardiologist that specializes in heart failure, and I don't think that every single patient with heart failure needs a cardiologist like me.
Yeah.
But first, see a general cardiologist and get a better handle on the diagnosis. Answer those questions. Why might I have this? What are the underlying disease processes that lead to it? How can I treat it? And how bad is it? Now, for folks who have what we call advanced heart failure, if even with medicines you stay symptomatic, or if you might have a cause of it that your general cardiologist isn't quite comfortable caring for, one of those causes is that inflammatory cardiomyopathy. That's where physicians like me can step in and say, okay, we've done some advanced training in this disease. Let's help think through these questions at a deeper level. But just, seeing a general cardiologist, answering that first question, why do I have it? How can I mitigate that causal risk? And then what medicines do we have? Because the other piece of good news for systolic heart failure is we have excellent medications. These really make a huge difference. Patients will feel better, they will live longer, and their ejection fraction, the squeezing function of their heart, can improve.
So, I just want to take us a step back. So is there a mild, moderate, severe? Everything in medicine has mild, moderate, severe. So can we talk about mild heart failure, moderate, and severe, and, how would patients put themselves in?
Right. One thing that people focus on a lot is that number, the ejection fraction that I mentioned. And it's an important number. We do base some treatment decisions on that number. But I tell patients ejection fraction is sort of like age. It's just a number. The most important thing to me are your symptoms. I've seen patients that have ejection fractions of 10%, 15%, and they feel great, relatively great. That's a much more reassuring patient to me than one who might have an ejection fraction of 30% and can't make it down their hallway without feeling short of breath. So the symptoms are how we primarily stratify patients into mild, moderate, severe. And there's a classification we use called the New York Heart Association class, NYHA. And you can really just use that. So NYHA2 is where you are symptomatic doing very strenuous things. NYHA3 is where you're symptomatic doing less than strenuous things, maybe walking down the block or walking across your house. And NYHA class 4 is when you're symptomatic just sitting still.
Yeah.
You're just sitting still talking to people. And I have patients that they'll call me on the phone and they're running out of breath halfway through a sentence. Obviously not a problem that I have, but yeah, you can tell they're symptomatic on the phone and you say, you got to come into the hospital.
So when a patient comes like this, I think the first step, you always make sure it's not blockages, because that's something fixable pretty quickly. And let's say we've taken care, we've sent them to Arasi Maran and she's taken care of the blockages. Then But if there are no blockages, what are the common medications you would start these patients on?
Yeah. There are now 4 classes of medications that are recommended at the highest level of recommendation by our guidelines. And in no particular order, there's a class of medicines called beta blockers. So these are medicines like metoprolol or carvedilol. And I tell patients, these are like a chill pill for the heart. They just tell your heart, calm down, don't work so hard, rest a little bit. It's a little counterintuitive. You already got a heart that's not squeezing well, but study after study has shown in the long term, this leads to improvement in squeezing function and improvement in symptoms and longer life. There's a big chunk of medicines that we call angiotensin antagonists. There's really kind of 3 classes in there. The newest medicine on the block here is a medicine called sacubitril valsartan. The trade name is Entresto. This medicine has been, over the last kind of 8 to 10 years, a game changer for us. Patients really feel better. And then there's a class of medicines called mineralocorticoid antagonists, spironolactone or eplerenone. And then the newest medicine class to get approval are SGLT2 inhibitors. These were first developed as a diabetes medicine, but they turn out to be excellent heart failure medicines. Again, patients feel better and live longer on these medicines.
So with these medicines, do patients, I mean, let's leave the most advanced stages away. Like we'll talk about the mild to moderate ones. Can they come back to leading a normal life?
Yeah, it's really amazing. And I mentioned that a satisfying part of my job is telling patients that they have a heart who are waiting for transplant. Maybe even more satisfying is telling a patient, you're not going to need a heart transplant. Because when maybe when you came to me, you were terribly sick and your ejection fraction was 10%. I have multiple patients I follow who have normalized their ejection fraction, have totally normal squeezing function now after starting these medications, and they live full and normal lives. That's really amazing. And I feel lucky to practice in this field at a time when I have these medicines to offer people.
Absolutely. And they are also the look of surprise. What? My heart function is normalized? And I think that look is absolutely priceless. But having said that, there's another very common questions patients ask. Can I now stop taking these medicines? My heart function is normalized. Can I now stop taking these medications? What is your answer for that?
Yeah, it's a question that we've wrestled with in the field for the last half decade or more. Is can patients do it, or is there a subset of population of this patient population who can do this? So they did a clinical trial, gosh, it's maybe 4 or 5 years old now, where they actually had half of the patients who had recovered their ejection fraction, stopped the medicines, and half didn't. And it was unequivocally bad to stop the medications. Their hearts got weaker, the ejection fractions went down, and they started having heart failure events, admissions to the hospitals, shocks from their defibrillators. And what was really sobering is when they restarted the medications in this arm, many of the patients did not recover their ejection fraction.
It almost like the heart gets pissed off and burns out or something, right?
That's right. It doesn't respond as well to those medications the second time. So I tell patients, with very rare exceptions, don't stop these medications. Even if you're feeling great, even if your ejection fraction is recovered, we don't stop the medications.
So now you talked about devices and ICD devices. Can you briefly just touch on that? Which patient category do you send them to get devices? And is there any, can you improve ejection fraction with devices itself?
Mm-hmm. Yep. I think it's important to kind of like delineate devices into 2 categories, and these are overlapping. So one set of devices are what we call defibrillators. So the way I explain it to patients is if you ever watch a medical show and you see someone, have a code and the doctor's running there with the paddles and they shock the heart, that's a defibrillator. But we can put a little teeny tiny one inside. Mm-hmm. So it's a device that goes fully implantable, and it just watches for your heart to have that deadly rhythm problem called ventricular tachycardia or ventricular fibrillation. If it does happen, the device will shock your heart back and restart it. The patients that we're talking about, these low ejection fraction patients, they're at a much higher risk of having that deadly arrhythmia. And if their ejection fraction does not improve with the medications, or if they ever have this arrhythmia just spontaneously and we are able to get them out of it, they need a defibrillator. Now, the other class of devices are these specialized pacemakers. These are called resynchronization devices. Some of my patients have abnormal electrical activity when their heart is squeezing normally. Mm-hmm. So and the way I explain it to patients, I use my hands. I say, instead of squeezing like this, one side of your heart squeezes first and then the other side. So your heart kind of does this. And that is not very efficient. So we can use a pacemaker to reenact this kind of squeezing, which is very efficient. What's really striking is there's a percentage of patients that you put them on medicines, they don't respond, their ejection fraction stays low, they feel bad, and you put this resynchronization device in and they respond. Their ejection fraction may normalize and their symptoms go away. That's really rewarding as well.
So, another big part of all of this, we kind of touched on it in the beginning. We talked about obesity, diabetes, hypertension. What happens to these patients who now have a reduced ejection fraction? And do we ask them to exercise? They are short of breath, they're symptomatic. How does exercise fit into this?
Yeah, it's a great question. So we do ask them to exercise. And in fact, we have studies to show that monitored, graded exercise can be therapeutic. And it's not necessarily that their ejection fraction recovers. I have many patients that say, I'm going to exercise my heart stronger. It's just a muscle, right? But that's not necessarily the case. What it does do is train the rest of your body to handle and adapt to this physiologic state much more efficiently. So we will send our patients to a program called cardiac rehab. I tell patients it's like a gym with a cardiologist watching over you and prescribing you graded exercise. And we have good studies to show that if you ever need to be hospitalized for heart failure, when you leave the hospital, if you are referred to cardiac rehab, you feel better and you stay out of the hospital. You have less heart failure in the future.
So how much is there is there too much exercising for these patients?
Yeah, it's a tough question to answer. What I counsel people is listen to your body. We all we talked about our exercise journeys earlier, and there are definitely times when I was out running and I think, okay, I'm really tired, but I'm going to push through. I'm going to, this is going to be a growth session. I think it's harder to tell my heart failure patients to do that. And so I say, listen to your body. If you're out exercising and you feel short of breath or tired, stop and rest. And maybe next time try and go a minute or two longer. It's where a place like cardiac rehab can provide guidance. They have exercise physiologists there that are watching vital signs, heart rate, respiratory rate, oxygenation, and say, okay, you've gone far enough now. It's time to stop and rest. And the next session, we're going to go a little farther.
And, again, we talked about obesity and diabetes, hypertension, etc. How much does modifying these risk factors help in the long-term outcome of these heart failure patients?
It's a little counterintuitive, and I think it might be something we don't fully understand. So it's very clear that obesity in the general population is a risk factor for developing heart failure. But there's a well-described phenomenon called the obesity paradox, which is once you develop heart failure, if you're obese, it might actually be protective against heart failure events. Now, I think the explanation for this is the folks with really advanced heart failure, where their heart is not squeezing blood around at all, they lose weight. Their body starts losing muscle mass. They get what we call cachectic or malnourished because every calorie they take in is spent keeping their heart squeezing and they can't spare it for anything else. So it's probably that observation is driven by the really cachectic advanced heart failure patients. It is increasingly clear that losing weight through diet and exercise with heart failure will make you feel better. Losing weight because of advanced heart failure, there you can't use your calories, that's bad.
Yeah.
So I think what I don't want people to hear is that if I have heart failure, I should eat as many donuts and Big Macs as possible. That's not good. Because I think that observation gets misinterpreted a lot.
Absolutely. Another common, with the weight loss medications and bariatric surgery, do you send your heart failure patients for bariatric surgery or even prescribe them the weight loss medications?
We do both. We do, yeah. So I think the advent of the GLP-1 agonists like Ozempic or Wegovy,
Jaro, whatever. Yeah.
yeah, it's really changed the game. They're effective weight loss medications, and there are really a couple of reasons why I'll send patients. One is for symptom improvement; they feel better. But oftentimes, for patients who are approaching that decision about is it time for a VAD or transplant, we know that if they're obese, they don't make it through those surgeries well. And so if we're able to project, in 6 months, in a year, you're going to need this therapy, we can start these weight loss medications, or we can plan weight loss surgeries such that by the time they need those therapies, they are candidates. They can lose enough weight to be a candidate for either transplant or LVAD.
So, this is a question, honestly, I don't know the answer to, and I would like to get your opinion. How about strength training? Does building muscle help patients with systolic heart failure?
Yeah, that is an active area of research. We have lots of research where folks are doing, even very advanced imaging like functional MRIs about how the peripheral muscles use energy in heart failure. Mm-hmm. And there seems to be that energy utilization system is broken. The peripheral muscles can't extract oxygen as well. They don't use their ATP, that little energy molecule, as well. But things like putting them through low weight, high rep strength training can help. And it is an important part of our cardiac rehab program. Again, I don't think it's making the heart stronger. No. There's this idea that it's a muscle, we'll just, build it up. True. But it retrains those peripheral muscles to be more efficient. And that's what you need to get around and do stuff.
So, and, this is another topic. We've gone back and forth. Even in American College of Cardiology, I've heard different opinions on this. Salt intake.
Yeah. Yeah. Gosh, it's a tough one. I will say that there's a mismatch between what seems physiologically plausible and what the evidence is actually showing us every time we look, at least recently. The idea being that in a patient with heart failure that tends to get congested, that gets too much fluid and has swelling, if you eat a lot of sodium, that water follows sodium, and you just hold on to extra water, and that will exacerbate heart failure. So for decades, and even currently, many have recommended sodium restriction, and to really low amounts, like 1,000 milligrams a day or less, which is exceedingly hard to do in a Western diet. That's the biological plausibility part. The evidence is whenever we actually look and try and randomize patients to sodium-restricted versus unrestricted diets, it doesn't seem to make a difference, including as an inpatient. These are hard studies to do. It's very hard to make sure that someone that's randomized to a sodium-restricted diet is actually following it. But I think the preponderance of evidence is leaning towards that maybe we don't have to be quite as severe in our sodium restrictions as we used to recommend.
See, I give this recommendation that don't add more salt to the food. Just, whatever the food is made, let it be made, but at the table, don't pound it with salt. Is that a fair, moderated solution?
Yeah, I think so. And I think there are clearly kind of categories of food which can get patients in trouble. A lot of your prepackaged
chips and salsa.
Chips and salsa. Patients will pound pretzels. A lot of your canned soups, the sodium content is just astronomical. Deli meats. I think also there's a dangerous misconception, and this has permeated medical providers as well, that if a heart failure patient eats 5 pretzels and decompensates, that it was the pretzels that did it. You should be able to, normal physiology, you should be able to eat 5 pretzels and not end up in the hospital. That's a sign their heart failure is really, really bad.
Now, another question is, we talk to our patients about weight gain, daily weight checking and how moderating a weight. And we all tell ourselves, there's no way you can, gain 3 pounds overnight or 5 pounds over a week or something like that. Can you talk about measuring weight and what does that mean to a patient with heart failure?
Right. One of the most effective ways we have of keeping these folks out of the hospital is managing their congestion. So keeping that extra fluid off of them. We do this with a variety of mechanisms, but most commonly it's diuretics, making them urinate out that extra fluid. And it's a challenge to try and track what is your fluid status doing every day. One of the kind of low-tech ways we have of doing it is just weighing the patient. If you're more congested, if you have more fluid on you, you weigh more. And so if a patient is rapidly gaining weight, that's probably not caloric or food-based. It's probably fluid. And we can ask them to take an extra dose diuretics or call us for more guidance. And we have some pretty high-tech ways of doing this as well. We can implant a little pressure sensor monitor in the vasculature of their lungs that measures pressures. And it will send us a reading every day. And we can say, okay, your pressures are going up. But it's a lot cheaper and easier just to have them step on a scale every day and track their weight.
With artificial intelligence coming up and, do you think there's going to be a future where everyone's going to wear a watch and we're going to have a CardioMEMS or some device inside our vasculature and be like, hey, patient with heart failure, go take an extra tablet of diuretic? Do you think we'll get there?
I think so. Some of our high-tech ways of monitoring fluid status, I mentioned the CardioMEMS, that pressure monitor. We can also leverage some of the data we get from defibrillators and those pacemakers. We can look at how well the tissue is conducting electricity, called thoracic impedance, and that can tell us about the fluid content in the chest. So there's a lot of data out there we can use to track congestion. And it's been shown that if you really stay on top of that data and act on it quickly, that you can keep patients out of the hospital. The problem is finding the people to dedicate towards that process. So you need someone to be tracking that data, contacting patients, following up with them. It's a lot of person hours. And so the more you can automate that, whether it's artificial intelligence, machine learning based, or just a more simple algorithm that patients can follow, I think there's a pathway for success there for sure.
So, Brian, I know you're getting ready for a heart transplant meeting, so I'm going to end us. But if you want to summarize, if you want to give some parting words of wisdom to a person who's like questioning themselves, is something wrong with me? Or what should I do right now? Any parting words of wisdom to that person?
Absolutely. So I think if you have any of the symptoms that we've discussed today, don't hesitate. Don't wait. Go talk to your primary care physician and say, look, I'm having these and it doesn't seem normal to me. I heard a podcast about heart failure. What do you think about an echocardiogram or a blood test? If you have a family history of heart failure, it's not unreasonable to ask for a screening echocardiogram, EKG. And then if you've been diagnosed with heart failure, you want to establish care with a cardiologist because the medications and the lifestyle changes can make a meaningful difference in how you feel, can keep you out of the hospital in the future, and give you a longer life.
Perfect. Brian, thank you so much. I know you have a busy day coming up, so thank you so much for taking time. I absolutely enjoyed this conversation. I hope people find it useful as well.
Thanks, Arasi. This has been great. Thank you.
Bye-bye. Thank you so much for listening. If you found us valuable, you can subscribe to the show on Apple Podcasts, Spotify, or any of your favorite podcast app. And also, please consider leaving us a rating or a review, as that helps others find the podcast too. I hope you have a great week ahead.